Thank you so much, Bleden. Good afternoon, everyone, and thank you everyone for being here. As Bleden mentioned, I'm Brad Herbig, and I'm a senior fellow with the McKinsey Health Institute, where I lead our disease burden and analytics research. And I'm passionate about how we can break down silos to help address global health's biggest challenges. Continuing on today's theme of convergence, our next panel will focus on the integration of policies, and we'll explore the following three themes. First, how governments can implement multi-sectorial policy plans for obesity and NCDs more broadly. Two, which actions are needed to mobilize funding towards that end. And three, how stakeholders can deliver implementation at scale. Let's begin first with the reality that we can no longer afford to ignore. Non-communicable diseases now account for more than 46 million deaths globally each year. But mortality alone doesn't tell the full story. These conditions also account for nearly 750 million years lived in poor health every year, affecting individuals, their families, and entire societies. And as discussed in the last panel, obesity is increasingly prevalent in both high and low income countries and is one of the fastest growing drivers of this burden. But here's the critical point. It's not inevitable that this problem has to continue. In our research at McKinsey Health Institute, we have found that if countries were to scale up access to proven, cost-effective interventions, we could prevent up to 28 million deaths every year and add nearly 400 years of healthy life globally by 2050. The economic return is equally as compelling. A healthier population is both more able to work and is able to be more productive, which could add an additional $11 trillion to global GDP by 2050. And yet, action continues to lag. Why is that? Because obesity and NCDs aren't just health issues. They're systemic challenges that are shaped by the environments we live in, our food systems, urban infrastructure, education and labor markets, and the policies that govern them. In our research, more than a quarter of the impact of interventions come from interventions centered outside of the healthcare system. The reality is clear. No single ministry, sector, or stakeholder can solve this alone. We need collaboration and financing across sectors and a commitment to see health not as a cost, but as an investment, one that improves lives and strengthens communities. That's why we're here today. This panel is about moving from commitment to coordination. We'll hear from leaders across politics, public health, and civil society, all of whom are helping to reimagine what an integrated NCD and obesity policy can and should look like. And with that, I would like to welcome our esteemed panelists to the stage. Great. Well, thank you all for joining me up here today. I'll start with a few brief introductions before we dive in, and I believe we should be having one additional panelist joining virtually as well. So I'll start with Dr. Guilherme Duarte, who's the Executive Director of UNITE, a global network of parliamentarians advancing public health leadership or political leadership in health. With experience in global health governance and diplomacy, he has previously served as part of Portugal's permanent mission to the UN and has engaged with organizations like WHO, Gavi, and the Global Fund. Next, I'll turn to Daniel Mora-Brito, who's responsible for the Global Health Workstream at IQVIA's EMEA Thought Leadership Team. His work explores current and emerging trends within the realms of global health security, health system strengthening, and equitable access to healthcare with a focus on low and middle income countries. Dr. Jackie Kassouf is Vice President at the International Diabetes Federation, a board member at the NCD Alliance, and is the founder and president of the National Diabetes Organization Dialeb, a leading diabetes organization in Lebanon. And last but not least, coming to us virtually, we have Mike Farrar, who's the permanent secretary in the Department of Health for Northern Ireland and the CEO of the Health and Social Care System. He has a long work record of leading and advising health and social care systems across the world. And Mike, I would like to actually start this conversation with you. And really go from the wider picture before we can then go into more specific examples going forward. So I would love if you could help us frame the conversation a bit of what is the current state of cross-sectoral collaboration around obesity and NCDs, and what can we learn from what is and isn't working?
Thanks, Brad, and thank you for inviting me onto the panel. I think Northern Ireland has a very interesting governance model, which is not atypical. We effectively have 9 separate government departments, all which are legal entities in their own right, and then we have a power-sharing executive at the top. And what that means is that the system is actually designed not to promote cross-government working, but almost to kind of perpetuate the sense of government departments being responsible for their own vertical. And of course, the thing we know about health spend is it is absolutely horizontal. So at present, we're working hard to use our health budget to help promote educational attainment, to improve on economic inactivity, to develop economic growth in life sciences, innovation and research. And all of that is effectively being done, if you like, in a way that actually tries to challenge the system rather than as a result of the system. Now, I think we're not atypical, and I've worked in a number of countries with similar problems. And what we have to find really at this early stage in trying to tackle this huge problem that you've outlined about non-communicable disease is the ways in which we can get alignment between policies, not just within government, where we have the cross-sectoral working, but also within the great family of health, where effectively we have divides between mental, physical and social health, for example. And so what I find in the work that I've done and what we're trying to correct in Northern Ireland is almost that the system is built to militate against what we would want to do, to work in a cross-sectoral, cross-government way. And where that leaves us, and I'll make this my last point by way of introduction, is that you rely on the quality of the leadership to find the right mindset to work despite their systems to actually get the results we need in terms of improving lives and reducing the burden of non-communicable disease.
Thank you so much. Yeah, I think it's very interesting that the structures themselves lead to some of the barriers, and really thinking about how that leads to what needs to change for us to have more collaboration. I'd love to turn next to Guilherme. I know that you have the view through your organization to a bunch of different parliamentarians across different countries, and I'm curious if you have seen examples of places where, even if it's in a specific example, some have solved more of a health and all policies approach, where you have multiple sectors actually collaborating towards health. Would love your thoughts.
Yeah, thank you so much, and thanks for having me in the panel, and thanks so much for the Global Health Connector for convening us all here. I think so, but I would like to have a note on what the previous panelist also said, that I believe that the current state is a bit of a state of confusion in terms of the, and I explain why I'm saying this. I think there's so many competing priorities, so many voices, so many topics. Now we're talking about obesity. The day before was another specific thing. The last year was tuberculosis or HIV, and I think that it's very easy for decision makers to just stay in a state of inertia, because institutions promote inertia, the system promotes inertia, and it's better if you don't change anything. I also have anecdotal evidence on the opposite of health in all policies. Actually, I'm not going to name the country not to put it to shame, but something that the Ministry of Agriculture actually openly advocating for people to drink wine, because it's their turf, it's his turf in terms of the consumption, and he thinks it's an economical gain to actually put that. even against everything that health stands for. So I think that we're still seeing more of not health in all policies than actually episodes of leadership. Of course, there is, and our network also promotes or tries to promote good examples, but in the end, it's very much about the leadership of parliamentarians themselves, and of course, the state where they're inserted. Just on a brief note, also, usually policymakers, parliamentarians, they also obey to very short cycles. So the cases have to be presented in a very immediate success type of product, which it's not undone, and it definitely can be done. We do have some successes to present as well, namely on the tax, on the foods and beverage taxes, which have been very successful, also in a bit of a marketing shape, which is very interesting. How then the brands, they don't mind to do the work together with the decision makers, so there's not a war in itself between economy and health. They don't need to be opposed, and so we do have some few good examples in there. But usually, I think they're very dependent on individual leadership, on a confluation of factors that promote these good practices.
Yeah, absolutely, and it sounds like really the alignment of incentives that different parts of different stakeholders have for what is important for their day-to-day that really can drive some of this. With that in mind, Jackie, I'd like to turn to you and ask if there are any examples that you've seen in kind of your advocacy work of ways that you have been able to really reach the kind of different sectors that are maybe not just health but others, and some of the lessons we could learn from that.
Thank you, Brad, and hello, everyone. Thank you for having me here today. This is, I think, is a very important platform to express things and seek the integration we are seeking. And I would like to build on something Guilherme mentioned, which is the short term of the decision-making people. We call it a political declaration. It's made by politicians. They are there for a very short term. So what we need to leverage on is the sense of urgency. If we can play on the sense of urgency, then it's a win situation. I would like to mention something that's dear to my heart, that today, the 23rd of this month of September, marks the 75th anniversary of the International Diabetes Federation. So I think this deserves a lot of respect. It's been here, it's been around for a good time. It's not an old organization, as our president said today. It's an experienced, a wise one, and I'm very pleased and honored to be a vice president. So if I were to speak about my experience in wearing several hats, and you mentioned the several organizations I'm delighted to collaborate with, including my own. So I bring the perspective of global organizations versus the local context of a small organization in a small country in the Middle East called Lebanon. What I see happening is that if we understand the concept that everyone has a role, we understand what that role is, then definitely we get the impact we desire. But when we keep making noise for the simple sake of doing noise, it's not going to work. I'm going to give a few examples, and as the lady in the prior panel said, usually I don't put notes. I'm a very spontaneous person, but these deserve to be mentioned. So, for example, we have always to learn from the best practices, and that's why it's worth mentioning. If I were to speak about the adoption of health in all policies framework, for example, we have in the MENA region, specifically in UAE, they introduced the National Nutrition Strategy, and that was a first in the region, something to build on and very scalable to other countries that hopefully we will be learning from. Also, if I were to speak about more initiatives that are maybe still not so big, but they are creating an impact and they are in the pipeline. I would mention, and forgive me for being fanatic to my region, but it is what it is. We are human and we have to admit that. So in Saudi Arabia and Bahrain, for example, they implemented successfully the taxation on sugary beverages. It's still not there, but it's working, and we can, build on it. And let me mention something outside the MENA region, which is an experience that happened in Finland, where they pioneered the approach by embedding health consideration in all sectors, like from transport to taxation. They really did the model of integration that we talk about. And the Eastern Mediterranean region, again, oh my gosh. I didn't notice that my fanatism translates into the words and the examples I'm speaking until I'm here. So going back to the impact of a small organization, we started a model of collaboration. We are a national diabetes organization, 15 years old. I see it as a very small organization compared to the International Diabetes Federation, the NCD Alliance, to so many others that I collaborate with. And yet, we started a program to collaborate with municipalities and with schools because we didn't get the good ears from the government. We started implementing, then we went to talk about policy. So sometimes you have to go the other way around to get to where you want to get. So municipalities were like, what do you mean, like nutrition and sports? Yes, you are the local government of your community and you have a responsibility, and we are here to tell you what that responsibility is. Do you want a healthy community? And of course, yes is the answer. So let's give spaces for the kids to play sports. Let's invite the community for a yoga event. Let's do a march on the occasion of whatever. So we started with this difficult beginning, yes. We didn't have a lot of acceptance in the beginning, but when you want something and you work with perseverance, you work with insistence, you don't get tired, you don't take no for an answer. Even sometimes because they're tired of seeing my face, they would say, yes, let's do it. So they don't see me anymore. So the point here is even a small organization from wherever it is in any remote country on the globe can create the impact. But then we are scaling from bottom up. We can also do the opposite, taking advantage of the high-level the political declaration that's happening here. And guess what? Each one of you being in New York is a responsibility. We will walk from here with a paper being announced tomorrow. It will remain on paper if we don't do something about it. From talking to implementing, there is a world of difference. And we are here in charge of making sure our governments, our ministers, really work on the implementation. Otherwise, we will meet here next year and the year after and 4 or 5 years from now to talk the same things, and we will be, in the same place. We don't want that. Does any one of you want that? No. So yes, we have the responsibility, and we have to carry out the voices we hear and the talks that happen here. We need to scale them in our own communities, and we need to make sure whatever is in the political declaration. I personally have some frustrations, but I want to be the positive person that I am and see the good side. We have advanced. We're not there yet. Maybe we will never be there, but at least we are progressing baby steps. So we have the responsibility of implementing this political declaration and keep nagging and working and talking until we see more progress in the next one. Thank you.
Great, thank you. That was really great. And I love the example of if it's not going to come top down, do it bottom up and then say, okay, now what? So I think that's wonderful. Daniel, I think we'll go next to you. I'm curious, with some of these barriers that we've been talking about, some of the structural barriers, some of the kind of short-termism, what you think could be some solutions to helping overcome some of that?
Thank you, Brad, and thanks again to the Global Health Connector for the invitation. So, for those who do not know the company that I work for, IQVIA is a global corporation that focuses on bringing together intelligence to generate better healthcare for everyone, everywhere. So we're basically in the business of data sciences, and data is our bread and butter. And clearly, we see a strategic value of data in changing the landscape or optimizing the way in which we work around many of these things. So, and I want to actually use the Guilherme's baseline, in indicating that over the last few years we've seen this huge fragmentation in how we are approaching healthcare, or basically global health issues. Every year we have a political declaration. Those political declarations come with a huge set of commitments. And some of these things can generate a lot of siloed responses, right? So everybody is running towards their little silo, trying to figure out how things need to be done there, and then forgetting the needed connections that will make sure that we come up with policies that are properly integrated, and they're moving things forward in a more holistic way. So when it comes to the value of data, in the case of NCDs, and thinking now that obesity is bringing us all together, we have been advocating really strongly for the need to establish obesity registries, right? And yes, the reason why this is so important is not so much to understand how patients are, the treatment is evolving, and we're also calling for a lot of longitudinal studies to see how these new medications that are in the market are bringing benefits, and how those benefits can be measured, and so on. Beyond the issue of obesity, we believe that it's extremely important to bring NCDs into those registries. And this is particularly important in the case of low and middle income countries. We are trying to understand what's happening. We are trying to make these calls to action to governments and different multilateral stakeholders, civil society, and so on, to actually bring the right level of solutions that we need for everything that's happening in the NCD space. But if we don't have the data to inform that, and I know this sounds very commonplace, but it's extremely important. It's like we're basically driving a car being blindfolded. So a key element to inform policy, to inform research and development, to understand how medicines are evolving in terms of the multiple treatments that we have now with anti-obesity medicines, GLP-1s and others. We need to have those data sets in place. It needs to be high quality, standardized, and interoperable data that can come to governments and different stakeholders, again, in the public space, to inform health policy. So I think that is an absolutely element that brings all of its different all of its different dimensions together to be able to generate responses that are coherent.
Yeah, absolutely. And as a data person, I completely agree. Yeah. And I think the other thing, and building on both what you and Guilherme were saying about the fragmentation, it's interesting, in one of the events I attended yesterday, we were talking about silos. And the first person started talking about, there's silos between diabetes and hypertension. And someone's like, wait, what about NCDs and mental health? And then someone else was like, wait, what about health and education? Like there are different levels of siloing that is going on. And I think it's interesting to really think about how do we break down those silos to actually move forward, and we don't just look at what's the next thing.
Brad, can I comment something here? We need to always remember that data is about people. If we stick only to numbers, then we're in the wrong direction. I'm not saying this in any negative way, all the opposite. We need to use and make good use of data and numbers to build on and make the lives of people who are in this data better. So we need always to keep this in mind.
Can I add on that? So, and this is actually, I'm very glad you mentioned that, because I feel that there is a very important distinction when it comes to this discussion on data, and it's something that we have been, again, advocating for in the context of this registry, is that it's just not real-world data, so just a data point without any interpretation, if you will. there's the evidence component of it and the incorporation of lived experiences from patients. Because the reality is that a lot of these therapies that we're talking about, plus global health interventions of any sort in any context, that have traditionally left that perspective of the patient or the person living with the disease, which is, I think, the right way we should call it. And that needs to be front and center in how we're informing the decisions that we're making. So I fully agree with you. I think that's exactly the kind of way we need to qualify it.
Thank you, Daniel. I would like to share with the audience that I happen also to be the mother of a daughter living with type 1 diabetes. So the narrative is very important. When we talk stigma, it's the wording we use is very delicate. What might seem very normal for us to say might be offensive to someone, might hurt the feeling of someone. And we are here talking about mental health and obesity, and we heard the panel before us speaking how important it is to eliminate stigma. But in order to do that, we need a major shift in the narrative. We need to revisit many of the policies, how they were written, and be mindful. And thank you for correcting, Daniel, and not saying patient. We are not using that anymore. We are saying people living with diabetes, people living with mental health challenges, people living with NCDs. And this is the basic. But there comes many more words. For example, the word adherence that was used in the previous panel, you might not think about it, but adherence means I'm dictating something, I'm mandating something, and you are obeying. Whereas doctors and the people living with a certain condition need to have both ways, two-way communication, where they engage into a discussion and you see what meets the needs of this person. Sorry, I've taken time, but this is really needs to be said.
No, it's very important. Oh, yes, please.
No, I just wanted to give a little step back in terms, because while you're discussing data, person, and also with the integration of policies, I was thinking that we can argue that the common connector is actually determinants, but then leads us to also how we began the discussion today, which is how hard it is to tackle determinants and how difficult it is actually for governments or policymakers to act on the determinants. So this would mean that we'd have a real integration in terms of health in all policies, because if we're expecting that health comes out of the health ministries, or then we're doomed from the start. But I think that really we should look at data a bit more spread, have perhaps health impact assessments that we were mentioning, before doing any major policies that change the landscape of the communities. And so, sorry, I just wanted to share because I think this connects a little bit all that we've been discussing so far, and I wanted to contribute to this.
Yeah. You have to deal with this, Brad. This is a passionate panel.
Yes.
You have to deal with it.
I much prefer a passionate panel than a non-one. And fourth even. And Mike, I wanted to return to you next. First of all, would you like to comment on that? Otherwise, I'm happy to. Would love to discuss kind of the. Oh, sorry.
Like you on the edge. Not to be passionate when you're thousands of miles away. But anyway, look. On the point of data and the information it tells us, I think there are three really good sort of insights that we can get from data. The first thing is, if we want to do cross-government working, then what we realise when we put our data together, whether it's criminal justice, health, welfare and benefits, education, is how much of our services are consumed by a smaller group of people. So bringing the data together is really important in terms of allowing everybody to have cross-government, a single version of the truth, which really allows us then to make brave decisions, which sometimes our politicians duck, but actually to say we should focus the resources we have on those people who have this level of need. And the reason that requires bravery is because most of our health services are open access, and guess what? The people who are most able to respond to education or most able to finance change are the ones who take it up soonest, and we widen health inequality. So data really important in terms of sharing and empowering cross-government working. The second point is that if we don't use our data properly and we don't really see people holistically and we only look at biomedical risk assessments of people, what you find is that very often the level of acuity that those people have, which says, okay, you meet a threshold for access to our healthcare services, actually, when you look at their personal circumstances, have a level of resilience that allows them to manage those. Whereas we also have a group of people with lower biomedical acuity, but who have less personal capability to manage. And if we don't find a way to get the resources to those, they end up being hospitalized, exacerbating their conditions, or worse, losing their ability to live independently. And so putting together health and social data tells us something about how we get better value out of the resource we have. And the final point I wanted to make is that when you look at what keeps people well, and I've been a healthcare provider and run health systems for many years, but what keeps people well is somewhere to live, someone to love, something to do. And all those things tend to be out with the gift of our healthcare provider services. But actually, if we understand those about the person, and I very much support the panel's view that this is about people, unless we understand people, then we're really going to focus where our resources go, and they are scarce against demand in the wrong places. And it really explains why we've been really poorer today in tackling, the huge growth in non-communicable disease and the burden that places, because we've really not used this data in an intelligent way to target the resources at those with greatest need and where we would get most impact for the money that we have.
Yeah, absolutely. And I think on that note as well, you mentioned how dividing the resources among the people, but even above the different silos who are impacting people's health. I'm wondering, Guilherme, if you could comment on how you would think about, especially from a parliamentarian point of view, about thinking about the allocation of resources towards health, not only within the health ministry, but more broadly, and what actually can enable that in kind of a political environment.
So, tough question, but I would say that you do have to have the will. You do have to decide what's the priorities, and I think that's probably the hardest thing when you get to this decision of power in terms of the decision makers, not only parliamentarians, because parliamentarians, they have a very specific role, and in parliament they hold two powers that they're very on their own, which is budget allocation, and they will suffer some pressures to put the money where it is, and this is where our organization also tries to advocate for evidence-based, for things that make sense in terms of technical, but also on the not only technical needs, but express needs also in terms of the people. And then the second thing, which is the lawmaking part, which is also important and very, very relevant if they want to balance the levers. So to your question in terms of where to balance resources, and I think that one of the other missions of our organization is actually to try to give them to educate them in terms of what the global health system is as a whole. Some of them, they're already champions on global health on their own. They're medical doctors, but not only, also health professionals, or at least very, very involved in health, and that's easier. But others, they are not. But we still get them in our network because I think that it's also important, and it's more votes when it comes to the decision making. And so I think that first they have to be aware, they have to be knowledgeable in terms of the topics. They have to be willing to do this right thing, and the third thing, they have to trust, and they have to at least follow evidence and technical requirements. Something that I wanted to say before coming up here, I was reflecting a little bit, which is sometimes in these panels, which is very, very good, I think, we take evidence for granted, but nowadays we don't see this as happening. And so we do have, even for vaccination, which is something that it's a very cost-effective intervention, and that's something that maybe the last 5 years no one needed to advocate for, we are seeing the progress fading. And so this just to say that policymakers, parliamentarians are just people like everyone else. Some also have strange ideas, and so this is also one of our roles and our jobs is actually to keep them with the right evidence and connected to this technical evidence.
Yeah, absolutely. A great reminder to always anchor back to the evidence. I really appreciate that. I think, Daniel, I would love to turn to you. I think, so we've talked a bit about allocation of government resources and things like that. I'm curious if you have any thoughts around kind of innovative financing mechanisms, or what are different ways of us thinking about how we can invest in health kind of beyond the typical?
Yes. No, that's a great question, and obviously very relevant today, considering the changes that we're seeing in the funding landscape in multilateral organizations and beyond. So I think before we get to the point of funding, a key element here is trying to really understand what unmet need is. I feel that we have been navigating a lot of the subjects with big statements on what assumptions, or big assumptions on what the costs are. We saw that, for example, last year as part of the conversations around, in the high-level meeting on AMR, and trying to see, okay, how much do we need to invest in new antibiotics, or how do we play, the game of investing in antibiotics while also ensuring, or achieving better stewardship. Obviously, a lot of models, emerging, innovative financing models were brought to the picture to figure that out as well, and we have lots of examples that have been working on that front. But before I go into that point, I feel that a key element for us was to really understand what the problem was, what was the circulation, what was the volume of circulation of antibiotics, for example, and then come up with, contextualize it and then bring the right resources into it. When it comes to NCDs, beyond obesity, we're really looking into a ginormous resource gap. If we look into it into perspective, we know that only 1% to 2% of development assistance for health is actually invested in NCDs. So yeah, it's a tiny margin or a tiny amount or percentage compared to what's invested or has been traditionally invested in infectious diseases. So something that we have done actually as part of our research recently is looking specifically into obesity and understanding how, for example, some of these new anti-obesity agents are impacting other NCDs or creating benefits for them. We're trying to combine a number of variables of social nature, going back to what Mike was saying earlier, with income per capita, understanding what's the health spending of each country, and first of all, having this baseline on, okay, what does it mean for these products to be affordable? What does it mean for these interventions to be affordable? Now, once you have that baseline and you have conducted that diagnostic, then you go into what the real tools you should be bringing to the table to figure this out from a financing standpoint. So I feel that in this case, a critical one, it's a lot easier to say it than getting it done, but there needs to be greater investment from government. So there needs to be more domestic resource mobilization. We're seeing that now with the shift in multilateralism, things moving more into the bilateral sector, that some countries are willing to work alongside donors to put some money forward, to mobilize their own private sector, to also invest more in these different things. And then we know that there is a host of different instruments, social impact bonds, all sorts of funding, blended finance mechanisms. I used to work for the Global Fund before I joined IQVIA, so Global Fund has been using a lot of these mechanisms to actually fund the development of new tools for HIV, tuberculosis, and malaria. So there is that, push incentives coming from the multilateral sector, which now I think is not going to be probably the best source. Bring in the private sector, definitely front and center to support some of these investments. And again, the first point I raised, also engaging governments more into, within their possibilities, understanding that we're in a time of severe fiscal constraints, to get them to invest a little bit more from their domestic resources to rebalance health budgets. Yeah, good. I know. That's what I'm saying. It's easier said than done.
I would only add development banks, perhaps.
Yeah. Ooh, and of course, sorry, thank you for bringing that big, important element that Guilherme just mentioned. Articulating a much powerful engagement from multilateral development banks. That is an incredibly important player, and I think they're trying to streamline a lot of their portfolios to see how they can create more impact as well. So that's, again, also in addition to emerging donors in regions that were not necessarily as involved in international cooperation. So I think that's where we're moving, yeah.
Great, thank you. And I think along that note, I'm curious in terms of if we think about, take a specific example of diabetes, kind of what would be some ways that you would think about the investment needed? What would need to be done differently? Who should play a role? I'm curious what your thoughts are.
Everyone? Yeah.
Sorry.
Everyone, as in government, as in pharma industry, as in people living with diabetes, as in civil society. We, civil society, get to be forgotten most of the time. And forgetting us has a cost. The cost is not having soldiers on the ground to implement what we are talking about. Having the funding is great. Having a political declaration is even greater. Who will implement? Somebody needs to do the dirty job. And I call it the beautiful job, because I'm so happy and satisfied with what we are doing, be it a small impact or a big one, it doesn't matter. Start doing something impactful. It doesn't have to be moving a mountain. It can be, bringing medicine to a limited group of people. You can be really working on access through that. Help with your government to change the policies. That's another thing. I think you wanted to ask me of some examples, or do I have time for that?
Sure. Yeah.
Because I really wanted to mention that how can we make this scalable? Because it's very important. I talk about small examples. If they stay small, it's never impactful. We need to scale them. And for that, we need 4 points that I would like to mention. Strengthening accountability. We need mechanisms for accountability. You will never give me money if you don't think I'm trustworthy. And I'm simply putting examples here. Nobody will ever receive funds if the organization they belong to lacks trust. So we need to have mechanisms to prove our accountability in order to get more funds, which is a key word here also. We can speak poetry until tomorrow, but if we don't have funds, we can never do anything. Leveraging, number 2 would be leveraging the financing for health. Again, we speak about many things that could be done beautifully in a very impactful way, but that needs financing. And financing is not only to the governments. That's another issue that I could speak about in a whole panel. Financing big organizations like to deal most of the time with governments. That money never sees the lights in the hands of small organizations. You need to keep that in mind and try to empower more the civil society and the local organizations who work at a level of a local context. That's where the impact is. Number 3 would be the community-driven scale-up. When I talked about municipalities and schools, I'm not talking about something big. Some municipalities are like, they have 1,200 inhabitants as population. So this is very small scale. But if you do it repeatedly, and then you bring that to the Ministry of Social Affairs, to the Ministry of Public Health, to Ministry of Sports, whatever it is called, then you scale it really much easier. And my 4th point is harnessing digital innovation. I may be a grandma, but I'm aware of if we don't keep up with digitalization, we are lacking behind. I may learn from my grandson many tricks on the phone, but still I'm aware of the power of digitalization. So that's another point that will tremendously help us scale whatever we are doing and scale the implementation, the much needed implementation, again, of the paper that we will see the light on Thursday, the political declaration on NCDs and mental health. And when we say NCDs, I never forget obesity, because it's a common risk factor between technically or across all the NCDs. So implementation needs to be scaled, and for that, all of you and all of us have our role to play and our responsibility.
Great, yes, completely agree. And Mike, I see that you, yes, thank you. Mike, I see you might want to comment.
I just wanted to put something very starkly into the room, really, which is if you look at the pace at which the OECD are recording economic growth per capita versus health and care spending per capita, doesn't matter whether you're a market economy, social insured, free at the point of taxation, etc., in terms of how you deliver health and care, virtually none of our countries in the OECD, comparator countries to the UK, can afford to carry on spending health and care spend out of their total public expenditure at the rate they are. And I can give you the very specific figures for Northern Ireland. 7 years ago, 46% of the allocation of resources for public expenditure that Northern Ireland received from UK government was being spent on health and care. If we look at it today, we're spending 52%. At that rate, we would be spending around 70% to 75% by 2050 on health and care. And guess what? That would be at the expense of spending on education, environment, community cohesion, transport, sport. And yes, I agree with colleagues on the panel who referenced this. It would be, it would be great if we could have a peace dividend where we weren't having to spend the money that we spend on defence. But the truth is that even taking that into account, we have got to, in funding terms, stop thinking our solution is more spend and start thinking it's managing demand. And I know all these panels have been about managing demand, but we probably need to be thinking about putting more of our budget that we do have into the demand side, possibly at the rate in which we've been over recent years increasing the rate at which we're employing more in our workforce, spending more money on the sort of supply end of our business, because that really goes nowhere eventually. And I would like to see the investment, and I do a lot of work around social financing and thinking about novel ways of funding, because most people's public purse, the purse of public expenditure looks more barren than it ever used to. So we've got to think innovatively about partnership funding of one sort or another. But it really is about putting that resource much more into the demand side and understanding that, earlier intervention, standardizing our pathways of care, connecting to ourselves as citizens, not about we know about our health, but actually what we feel about our own health, because that's what moves the dials. More education is helpful, but it doesn't do it alone. We have to tackle what people feel about our own health, and then to sort of promote change there. So behavioral science, etc., is a really good investment in understanding why we would change our behavior. And so that's the kind of area that I would like to see new investment in, not just pouring more money into the supply side solutions.
Thank you, Mike. I think that's a great point, and really thinking about the prevention side of things and how do you get upstream of kind of all of the challenges and the burden. I'd like to connect a few of the threads that we've talked in the last few answers around. All right, we understand more of the challenge. We have talked about a bit of the financing and kind of how it needs to come from multiple places, and there are multiple people who need to be involved in that. I'd like to move us to really thinking about, okay, what does that mean for implementation? Because I think, Jackie, to what you had said, we can have a political declaration, but until we actually act on it, that's all it is. And Guilherme, I'd like to turn to you and to get your thoughts around how we can think about actually taking those ideas and implementing, and what that takes in terms of kind of how people organize themselves and what could be effective there.
Yeah, so I would I really like that idea of rationalism as well in terms of the spending. So I just wanted to give this note, and I think that the way forward could be in fact, as the panel say, to interconnect NCDs and obesity and check exactly what are the best buys in terms of interventions. And this would mean a true analysis in terms of the economics, cost opportunity of things. There is no model law for every country, but I think that you could have a menu of selection that you could select for each country according to the epidemiological nature, to what data was telling you, without forgetting the people components and looking at and models a bit more close to the value-based healthcare, for example, for things that matters to people, so that you could customize as well the experience and the pathway of the patient. And so I would look at it as a conjoint group of maybe policymakers, but also very technical, capable organizations / individuals in actually creating a menu of next best investments. And then you would have to actually implement. But I think that a task force like this that would look not only at diabetes, not only at obesity, but how can we tackle all of the above at the same time in a cost-effective way, and in a way that would be adhered, I don't want, that would have, that it could be actually applied to the population in question that would have effect. And so I think that only with this interconnection you could probably simplify a little of the confusion that I started the panel to mentioning, and stop this putting everyone on the table so everyone feels included, and not choose selected silos and have this competition or the rat race to get our disease with investment there. Also, just on a small note, which is we know that the pressure of innovation brings to health systems, and we really do have to face it on a positive way because they bring more possibilities. But then I think public governments, they also have to have a threshold of saying only if this brings added value in terms of what I'm capable to paying. And I think this really should be stressed, and we shouldn't just run for every type of innovation that appears with a consequence of jeopardizing public budgets.
Yeah, completely. And I think one of the things that makes me think of is when you think about the benefits of better health, there are economic benefits of better health in terms of productivity and the things like that. There are some budgetary benefits, but often, sometimes not all of the benefits will accrue back to the health sector, who the payment is coming out of. So I'm curious, Mike, if you have any thoughts about kind of what are the best ways to either recognize those returns in terms of how you then prioritize across the things, knowing that you have limited budgets?
Yeah, I do. And I'll just say one thing about implementation, which is I probably worked in 7 or 8 countries. And one of the characteristics that I've observed, and maybe I've just been unlucky, but is that there is this gap, a sort of cultural gap between those people creating policy and those people on the ground delivering health and care. And what tends to happen is that people say, if only the people who created policy understood what it was like to deliver care, we'd get better policy. And the people who deliver policy say the policy is great, but if only those people out there had the ability to, change things and understand why that change is necessary. And so one of the things about implementing policy is to put a great premium on the cultural alignments of policy making and then delivering health and care systems. We have to work as one team. If we can get the context of policy right, people on the ground can deliver great health and care, and people can be healthier. If we bring that together, you have a much better chance of doing that. But my specific answer to your challenge is that we need to give our leaders of our health and care systems shared objectives where they get credit for budgets, mental health budgets to reduce reoffending rates and the pressure on prisons and criminal justice. At the moment, most of the incentives that I had as a leader in health systems were, how can you get more elective care to reduce waiting times? I wasn't being rewarded and politicians generally aren't, for actually using their resources to support these shared objectives that ultimately create wealth, which generates the ability to fund health and care, et cetera, et cetera. So my specific answer would be start giving our leaders in healthcare wider objectives and incentivize them on that, the way that some systems have simply incentivized delivering more health and care.
Thank you, Mike, for mentioning that. Actually, one of the biggest gaps is that people who write the declarations most of the times are not aware of the little details that happen on the ground. But I think the title of our panel is the answer: integration and interconnection. If we really implement that by sitting at a table with the key actors, with the people, stakeholders, everybody who is involved, and discuss and make them understand where they need to also make us understand if there is a them and us, then there will be one side of the story, one front, really deciding for the best policies to take. Policy advocacy is one thing that we are lacking across all diseases. And I've seen that happen. We have a new generation working on that. And I believe in empowering those voices. We do that at Dialab. We do it at the level of IDF. We are doing it big time at the level of the NCD Alliance. And I think this will be key in approaching, and they say, nothing about us without us. I think this is the most powerful statement I've ever heard. How can we put policies related to people living with certain diseases and conditions, and they are not there? As much as we can be professionals, we can be medical doctors, professors, it doesn't matter. If the person living with that condition is not giving an input on the wording, on the language, on what hurts them, on what makes them feel good, then we are doing nothing good to them. So nothing about us, and when I say us, I consider myself not part of the lived experiences, but the loved experiences, having a daughter living with type 1 diabetes. So yes, it's nothing about us without us. If we do that, we implement the integration, we do the interconnection needed, then every policy will have a triple effect, the butterfly effect that starts small and then becomes gigantic. Thank you.
Wonderful. I think that's an excellent point. And I see we now have another panelist joining us. Thank you so much for joining us, Amira.
Thank you so much. Thank you so much. And yeah. Thank you so much, and I'm so sorry for the delays, just New York and the UNGA.
No worries. I know the traffic out there can be very crazy. I would love to get your perspective. So we've been talking a lot about how governments can work across the silos to better invest in health, about how we can think about financing the many drivers of health, and for those who are not familiar, Amira is a parliamentarian in Egypt. I'm curious from your perspective as a legislator, what are the ways that parliaments and lawmakers can help actually facilitate that integration? And what are the lessons that you've learned from trying to do it in the past?
When I got to know about the session, I was extremely interested, because one of the main problems which we as legislators face all the time, and even the society as a whole, is the silos. It's that everyone is moving on one angular, single track. They're doing their best. They are putting the investments. But when it comes to policy making, if you don't have the holistic approach, you're not doing it properly. When we are talking today about the interlinkage and how can we go through obesity along with the other non-communicable diseases. In Egypt, for example, we suffer from very high obesity rates. And this comes connected to malnutrition, especially for children. And this doesn't leave anyone alone. Was it the rich or the very poor? Because by the end of the day, obesity is not about eating or not. It's about the quality of food you eat and your lifestyle. So if we, while planning the cities, don't consider places where people could walk, if it's not a walkable city, then as legislators and as oversight interventionists, we don't do our job properly. I mean, how can we find the minute connection? When I come later on to talk about the grand picture of putting investments into that, that's how we can push the government for health insurance that covers everyone. And it's very recently that we have a universal coverage that should be covering every Egyptian, but it's moving very slowly because we first considered in the first phase the cities and the governorates with considerable amount of people so that we could do the pilot within the coverage. But again, it starts in the media. It starts in the civil society. It goes along with the policymakers. And we take this to the tables of the science. I mean, if you don't have even the infrastructure for good research on how to tackle this from the pharmaceutical point of view, or even research on the intersection between how media could affect the young people, how media could educate the mothers on how to teach their children about what to eat and their lifestyle. Personally, I have gone through very rewarding experiences when we try to get the donors along with the responsibles from the government, and I initiated an NGO for this, to just make everyone in the civil space coming together. And when we get the civil society organizations that are very active on ground together, and when we got the pharmaceuticals and the donors who gave us the fund to start a nationwide campaign on advocating for healthy lifestyle and for the mothers who are underprivileged, how to cook healthy food. I mean, in ingredients that are cheap enough, in ingredients that are available, because availability is something else. Sometimes we see on Instagram and every single social media ingredients that are very healthy, very delicious, but they are not affordable to those who matters. Because when it comes, or available, because when it comes to economies at scale, when we are talking that there is no one safe until everyone is, it should be something that is feasible for most of us as a population. So in Egypt also we have a very important initiative which we extended also to African nations, which is 1 million healthy lives initiatives. So that's scanning the population, the whole population, for free against the non-communicable diseases. And that where we actually managed even, that was another success story I was talking about yesterday, how Egypt combated the hepatitis C virus. And that we got for that a gold tier from the WHO as a recognized successful story. And again, that was done in silos. That was done when everyone from policymakers to international organizations, to the WHO, to the development banks, to the civil society, which I consider extremely important, because there is an NGOs which are working on every scale from employability, because if you employ people, they have a source of income to eat well, to consider healthy lifestyle. So by the end of the day, this affects the other communicable diseases. So what I try to sum up here is that it doesn't work at all in any country, in any setup, if there is no political will, higher political will, and a movement coming from the ground, and politicians who are aware. And for this, that setup is extremely important, to get parliamentarians and policymakers and activists aware on how they are impacted themselves if these critical points are not tackled well.
Do you see the power of women from the MENA region? Thank you, and thank you for insisting on the role of civil society. As I was talking earlier, that most of the time we are forgotten, and they let us work in silos, by force, not by choice. So that is key. And I think the day we break those silos, we understand the importance of joining efforts, of creating one front where government, civil society, people living with the diseases, join efforts, and also with the industry and all stakeholders without competing. What are we competing about? In every single disease, there are 10 organizations, if not more. And I keep repeating, why don't we create one front? We cannot compete over people's health. We need to join efforts to really work effectively. And this is really not an option. It's mandatory nowadays. We don't have the luxury of time anymore. And you mentioned a very important point, which makes a vicious circle if one part is broken. You cannot tell people exercise, walk every day if you don't have a safe space and a good area where they could practice what you are telling them to do. Same thing, you cannot tell them drink water 2 liters per day. This is excellent. We all know about that. What if they live in a rural area where there is no drinking water? They have to buy it. So this comes, we need to break that vicious circle and start one by one addressing the problems, but not in silos, as a big front, having in mind first and foremost the well-being and the quality of life of our communities. Then we would have successful stories to share. Thank you.
And I actually want to continue building on some of the things that you're just saying, because bringing the perspectives and the voices of communities of people living with diseases is, yeah, on the political level, of course, is absolutely essential to be able to generate the level of action that we need. But in terms of, in speaking about, for example, clinical trials, if we think about clinical research, especially in regions that are severely underrepresented in terms of genomic information, I think that, at least in our experience, what we're seeing, and this is something that we ourselves are doing as IQVIA, because we're a clinical research organization, we're significantly more mindful of the views of these individuals, of trial participants, where we're basically shedding more light on their role in the development of this new therapeutic solutions. Because clearly, and again, this is another way of bringing data, going back to the beginning of our conversation, this is just not someone who goes into a lab somewhere in the middle of nowhere, who probably has to walk away from their source of livelihood and all of the implications that come with an individual moving from a rural area into, say, an urban center to be able to participate in some cases in a trial. All of that needs to shape the way in which we think around therapeutic innovation, on how we bring those solutions. So on the political side, is absolutely pivotal to be able to move action forward. To get action, to get things to happen. On the clinical research side, in terms of solutions, this has proven to be extremely important, especially when it comes to NCDs as well. And that means not only getting the perspectives of these individuals into the research work that you're doing, it also means ensuring that you get to understand what's the effect that this is also having in their communities, all the solutions that you're generating and the access that you're giving to some of this novel therapies in development. So that's basically just to add a little bit more of color into the whole community side of things.
I just want to add one little comment, but it has a big impact. All what we are discussing here are in normal settings. Just think for a minute how these challenges get multiplied when we have humanitarian crisis. And I know what I'm talking about because I've lived those in those settings. I've seen firsthand what happens to people when there is no access to medication. And guess what? NCDs don't stop. They don't take a break if there is a crisis of any type, whether be it a war, be it an earthquake or flood or whatever. And we have experienced almost everything in the MENA region, right? So imagine in normal setting, such big challenges, right? So when there is a crisis, those challenges, multiply them by 10. And people should be always at the center, especially people living with NCDs. Just think about this for a minute. A child with type 1 diabetes cannot afford not to have his insulin injection. It's a matter of life or death. We don't like to think about it, but it's true. It's a reality. So we need to think not only of policies for the good times, with all the challenges. We need to think of policies that could be implemented when we have humanitarian crisis. And if you think about it, I hear many people saying, let's work on readiness. Are you ever ready for an earthquake? I don't think so. So let's work on preparedness. This is the key word. We need to be prepared as much as possible, for whatever can come. And for us in the Middle East, as we have experienced different crises, from economic, especially in Lebanon, to the Beirut port explosion, to the banks not existing anymore. So we have financial challenges, we have security challenges, we have life-threatening challenges, and unavailability and unaffordability of medication. Imagine on those settings, what is the life of people living with NCDs like? So we need to keep that in mind. And I don't want to sound dramatic, but this is the reality of things. The reality that sometimes people don't like to think about or don't like to see, but we cannot ignore it. Thank you.
Thank you. I think that's a crucial reminder, and appreciate you making sure that we wrap up the core part of our panel with that thought. I'd like to, in the few minutes we have left, I'd like to open up for some audience questions.
There's someone. Yeah.
There's a gentleman raising his hand.
Two things. One, absolutely agree with Jackie. I chair the Crisis and Emergency network of the European Cancer Organization. That's exactly what we're looking, and it would be really interesting to talk to see how we can extend that from cancer into other diseases. So love to chat to you after in relation to that. But the main question was in relation to what Mike said and the reality in terms of health spend. Unfortunately, when defence spend goes up, health spend goes down. And one of the things that I'd just be interested in the panel's opinion on, one, how do we stop the waste? Because we're wasting a lot of money in health. Mike was referring to it in terms of not spending on actually what we need to spend on, but also overspending in areas we don't need to spend on. Cancer drugs, for example, we spend a huge amount, and in a lot of cases we don't necessarily see the benefit associated with it. But my question would be really in relation to how do we make sure that the workforce crisis that is right across the board, not just in cancer, it's right across everywhere in relation to health, how do we make sure that we actually address that? Because we're not going to be able to recruit people to get ourselves out of the workforce crisis. To my mind, the only way to do it is an actual system that allows us to integrate both digital and actual together, because otherwise we're not going to. We've just done a study in relation to that I can share with people afterwards to show the amount of money, but also the amount of people's time you can save by actually having a digital approach.
Yeah, absolutely. Mike, would you want to take that one?
I think it's. I agree with the questioner, but just one very specific example of putting together this problem of waste with best use of resources. There was work done in a city in England called Swindon around troubled families, and these were families that were at the attention of virtually every bit of public service: criminal justice, education, health, welfare. And what they found was that over the course of a 2-week period, those families were having something like 150 separate visits from different organisations. And they turned around, and this speaks very much to Jackie's point about bottom up. And they said, of all those people who come in your house, who do you value? Who do you trust? And they landed on 3 or 4 of the people who came in. So instead of sort of thinking about 150, they just empowered the 3 or 4 to have the ability to trigger the resources of the many agencies that came in, because they had the personal relationships. And what they found was that the overall use of resources by those families dramatically reduced, but also they improved in all those areas of educational attainment, healthier status, reducing reoffending. So there are things that we can do with our workforce as is, with the problem that the questioner raises, just to say, look, if you avoid these silos at the coalface of delivering care, you can really get added benefit. And I do agree with the point that give them the information, give the digital solutions, so they all see the same picture, and you can magnify that benefit significantly. That was a great piece of work, and I think we could do that at scale.
I would like to add one thing to what Mike said, and it's a key point. We don't need more resources. We need a better distribution of the resources. And one very important story I can share in few seconds with you. The day after the Beirut port explosion, where many people were without homes or broken homes, and they left all their medications and everything, we were on the ground asking people what they needed and then delivering the medication the same day in the evening or next day as we could. And as we were facing unavailability of insulin in most pharmacies, I was walking in one of those broken streets and I see a fridge full of insulin. I ran, it was like a magnet to me, like if I were running for my life. And it was one of the biggest global health organizations that I will not name out of respect because they do a commended job. But in that particular case, what I'm criticizing is the policies, not the people. And they told me, oh, we do have insulin. And do you know who needs it? I was like, are you kidding me? Do I know who needs it? I have tons of names. I know their homes. I know where they live. And they were like, yes, but we cannot give it to you because of compliance. So my point is not to criticize. Again, my point is if we think better of empowering the local organization in their local context and settings, we know the language, we know the culture, we speak the language, and I'm not saying the language as in Arabic or English or whatever language. I'm speaking, I know how to deal with my people. They flew someone from Brazil to live in a 5-star hotel in Beirut in one of the organizations. And with that money, we could have given 100 kids insulin for maybe 1 year. So we need to think about that, about the distribution of the resources. We don't need more resources. There is plenty of resources. Let's just spend them with conscience. Let's just invest in prevention and in the care of people who are the most vulnerable, especially in the low and middle income countries. Then we will be fine. And thank you for your question.
I just can't help not building on Jack's point when it comes to the resources and their availability. I want to pose a very quick question to the hall. Do you know anything about the food waste numbers in Egypt or the food waste numbers even in New York? Okay, so the FAO estimates the food waste per person in Egypt to be 50 kilograms per year in a country where 40% of its population is under the poverty line. So how do food waste connect with obesity and with NCDs? It connects perfectly, because if we have good food available to the people, they won't go to the fast food. They won't go to the food that is extremely non-nutritional and bad and causes all the severe health consequences moving on, especially for children. So food is there, and it is wasted because there is no such policy coverage that could be a law, which I introduced on combating food waste, connecting the Egyptian Food Bank with the authorities and with the civil society. So there are always connections which we don't see. Something else, I can't help leaving the hall and being in New York and not talking about the fund cuts. The cuts in health funds are going to be drastic to many places around the world. The work of the UNFPA, the work of the UNICEF, the work of the WHO, that has been crucial in combating many of the NCDs. And we don't see that away from how multilateralism is falling. Being a politician, I can't escape actually highlighting that every voice counts to the reversal of such, because the reversal of such is extremely important when it comes to achieving any of the SDGs at any setup which we're talking about, especially on NCDs and obesity. Thank you.
Thank you. Yeah, and Blevin.
So we have the last two questions for this panel, and they're coming from online. And Mike, I'm afraid they're both for you. I think they're both picking up conversations from earlier panels. So the first one is, Denmark achieved political party consensus for consistent policy, leading to EU cancer outcomes moving from poor to some of the best in Europe. Do you think that building this party policy is possible across multiple countries?
I'm an optimist. I would hope so. I'm a great admirer of Denmark and the Danish health system. I think they lead the way in many areas, and I'm also aware that Denmark people consistently vote themselves that some of the happiest people in Europe. So I absolutely believe it's possible, but I do think it requires a particular level of political bravery to be able to say some of these things can't be delivered with short-term fixes, that they do require collaboration across parties, and they require us to effectively use the evidence to shape our policy. And then the final point, which of course we dwelt on so much on this panel, is it needs to start with appreciation of the people's lives for whom those politicians serve. So I think it's entirely possible. I would struggle to come off this call if I felt that we couldn't do better around our political landscape than perhaps we're doing now.
Thanks. And the second question then was, do you believe that healthcare policy and healthcare systems need to embrace social media influences to tackle the many healthcare challenges?
Yes, I do. And I'll explain why very, very quickly, because I'm aware of our time. As far as the evidence that I've always worked on, there are three drivers that impact on our ability to take healthy decisions. One is what we know, one is what we feel, and one is what we believe to be normal. And the first two we've discussed, giving people more insights and education. The second is underestimated, but it's so important. What do we feel about ourselves, about our own health, that leads to taking healthy or unhealthy choices? What kind of environment we live in, which has been depicted by all the panelists today in terms of the level of distress that some people are in. But actually the third one, which is really important, I think, is that how do we understand what's normal is a big driver, particularly for us in our younger years, but it remains with us for life. In the past, if I had a very strange view of life, my peers, the people around me, would say, that's unusual, that's an abnormal version of what you believe. Now with social media, it means that if I have a slightly strange, extreme view of life, I can connect to someone across the world in different parts of the world who will reinforce that for me and tell me, no, that's fine. And so I believe that to be normal. Now we can allow that to go unchallenged, or we can embrace social media, which we have to, for the value it brings, and say we should be really using techniques to influence social media in a positive way, to be able to challenge extreme views, but to bring people an understanding of what healthy, sort of consistent views might be, particularly in respect of our own health and our conduct and behaviour. And I think we have to embrace that. I think we're a bit slow off the mark, but I would really envisage using some of those people who genuinely understand social media in a much better way than generally public servants do, to really sort of help us understand how you use social media to influence behaviour. Because at the moment we're leaving that vacant, and sadly too often we're getting the wrong messages, and you can see that with things like suicide ideation, etc. We've got to be in there pitching, we've got to take advice on how to do it, and we've got to be less passive in that space.
I really have to say something. Thank you, Mike, but I want to comment on that. Having myself a Ph.D. in public relations and communications, I believe in the power of social media, but like everything else, it's a double-edged sword. Like from transmitting policies and health benefits through social media to having a person saying, if you drink cinnamon every day, you can stop your medication. If you have diabetes, I mean, there is a world of difference, so we have to be really careful before the sector of social media platform is completely organized and there are laws and regulations. I don't think using it for health could be very convenient. I mean, in some countries it is, but I'm speaking about those countries that do not have regulations for the sector of, media, and especially social media, not the conventional one. So we need to be careful about that. And I want to make a comment, and allow me to disagree with love about what you said, Amina. Yes, we do have challenges in funding. We are completely aware of that. But being the positive person that I am since I was born, maybe, I always see an opportunity in the challenge. So maybe this is a call to action by itself to drift away from like the health sector, depending completely on pharma, to go to unconventional funding, to go towards somewhere else where we will not have, in some cases, some conflicts of interest. So let's look at the bright side. Yes, it is a major challenge, but there is always a window of hope, and that's how I see it. And let's look into that window of hope and bring on board new funders. I mean, I'm not saying to leave the old ones. I mean, things will change. We don't know when. But yes, it's a big window of opportunity to bring new stakeholders to the health sector. Thank you.
Great, thank you so much. And unfortunately, we have already run over time. So I'd like to take this opportunity to thank our esteemed panelists for the excellent discussion this afternoon. Thank you.